Hi, my name is Peter Carlobos and I will be showing you how to perform chest tube insertion or tube thoracostomy. Tube thoracostomy is a minimally invasive procedure in which a thin hollow plastic tube is inserted into the pleural space, the area between the chest wall and the lungs. This is indicated to evacuate air or fluid present in the pleural cavity. These include pneumothorax, hemothorax, pneumohemothorax, subcutaneous emphysema of the chest wall, and empyema. The materials used are the following: cut-down set, which includes the curved Kelly clamp or curved Mayo scissors, sterile gown, sterile surgical gloves, glass bottle system with underwater seal, chest tubes, povidone iodine antiseptic, sterile sponges, silk O with curved cutting needle, syringe with local anesthetic, vaselinized gauze, and plaster and gauze. Prepare the plasters and the gauze ahead of time for a smoother procedure. Tear long pieces of plasters and cut halfway at the midline on the gauzes. Then prepare the anesthetic with a 5 ml syringe on the gloved hand and the anesthetic on the ungloved hand. Aspirate and withdraw the anesthetic. Have the patient assumed to a semi-upright position with the arm placed above the head in order to have a maximal exposure of the insertion site. Then, identify the fourth or fifth intercostal space on the side of injury. This is done by first identifying the sternal angle or the sternomanubrial joint. This corresponds to the second rib and its costal cartilage. From here, using 2 fingers, walk down the interspaces on an oblique line. In females, displace the breast laterally or palpate more medially, but avoid pressing too hard on the tender breast tissue. Then locate the fourth or fifth intercostal space along the anterior axillary line. This point is the ideal location to insert the chest tube. This can be visualized with the triangle of safety, an anatomical region defined by the posterior lateral border of the pectoralis major muscle anteriorly, the anterior border of the latissimus dorsi posteriorly, the axilla at the apex, and the fifth rib at the base. Next, prepare the skin over a wide area of the chest wall with povidone iodine. Drape the area with 4 towels. Square off the planned line of incision. First, towel on the side nearest the surgeon, then place the other towels in the cephalad and caudal positions. The last towel should be placed on the lateral side opposite the surgeon. Secure the position of the towels by applying towel clips at its intersection. The gloved hand should not come in contact with the prepped skin. At the fourth or fifth intercostal space on the anterior axillary line, infiltrate the skin with a needle bevel up with a local anesthetic to block the intercostal nerve branches. Do not forget to infiltrate the pleura. Aspirate before injection of the contents. Make a 2.5 or 3 cm long skin incision well into the subcutaneous tissue. Insert a curved Mayo scissors or curved Kelly clamp and cut or separate the tissues through blunt dissection as to create a tunnel or tract in the direction in which the tube is to be inserted. This tract should be directed posteriorly, cephalad, and medially. Continue developing the tract all the way into the pleura. Entry into the pleural space into the pleura can be felt as a give or a sudden release of resistance. From time to time, remove the scissors or clamp and explore the tract by insinuating with a gloved finger. This is to make sure that the tract is going in the right direction and not on a subcutaneous space. After the pleural cavity has been entered, insert the gloved finger to explore for adherent lung. Then further enlarge the opening in the pleura using a large Kelly clamp and spreading it. Select the tube to be used. Take note of the locations of the holes and the distance of the proximal hole to the tip of the catheter. Grasp the tip of the tube with a long Kelly clamp so that the long axis of the clamp is almost parallel to the long axis of the tube. Measure the distance that you want the tube to extend into the chest and either note or make the proposed point of emergence of the tube with another smaller clamp placed on the tube at this point. If hemothorax is suspected, clamp the very distal end of the tube to avoid making a mess. Insert the tube into the chest using the large Kelly clamp as a guide. If a pneumothorax is suspected, point the tube anteriorly. If a fluid is suspected such as effusion or hemothorax, aim it posteriorly. Remove the large Kelly clamp as soon as the tube has reached the desired position in the chest. Palpate to ensure that the tube has entered the chest. Secure the tube by suturing it to the skin with Silk O. Wrap the free ends of the suture around the tube on opposite directions by making 4 loops. Then tie once again close to the skin to prevent slack from being incorporated into the suture. Only after these sutures are placed may the smaller clamp on the tube may be removed if used. Take note not to displace or advance the tube once secured. Then connect the tube to the underwater seal chest drainage system. Remove the clamp on the distal end if used. Care should be taken to do this step properly as this may cause pneumothorax if the tube is disconnected from the underwater seal. Place the Vaselinized gauze dressing around the tube, close to the skin to prevent any air leak. Thereafter, dress the wound with several pieces of sterile gauze around the tube. Obtain a post-tube insertion chest X-ray to check and confirm the correct position of the tube.